You talked about this tension where this rigid guideline adherence can actually be unethical practice, which that's going to explode minds. Like that, there's going to be brains that just can't be that way.
They're not human. They're non-human. And if we think of health and life cycles as being inextricably linked to all of those things, then it radically makes opportunities available for us to rethink the physical therapies in ways that can provide therapy outside of our musculoskeletal physiotherapy ways of practice.
What if following clinical guidelines could actually be the unethical choice? That's not a rhetorical question, it's a serious argument. And it's one of the first places we go in this conversation. This is part 2 of my conversation with Matt Lowe, who is one of the sharper thinkers I've encountered on what it actually means to practice well in a complex world. If you haven't listened to part 1, I'd recommend starting there, but this episode does hold its own. We pick up with Matt's work on epistemic fluency and critiques of value-based care, and then we move into territory I think every clinician needs to sit with. What AI is actually going to do to this profession, not in theory, but right now. We also get into something Matt calls the contextual architect and why the future of physiotherapy might look nothing like its past. We close with a question about ecological thinking and what it means to see the patient as inseparable from the world around them. We'll have you rethinking what is possible for future clinical practices. Let's get into it.
This is the Modern Pain Podcast with Mark Cartographers.
I want to get into something you spoke about in. I got a behind the scenes peek at your epistemic fluency paper. You talked about this tension where this rigid guideline adherence can actually be unethical practice, which that's going to explode minds. Like that, there's going to be brains that just can't be that way. So that's a provocative claim to say the least. I mean, especially with a profession where physio, we've really been staunchly trying to be, evidence-based and things. So that really is probably a tough pill to swallow. How do you make that argument as somebody who's pushing back on you on that? Because I think there's obviously some context that needs to be brought out into that discussion, which I know you're going to give me. But I thought that was
plain for sure.
I just when I read it, I'm like, I could just feel that I loved it first off, but because I agree wholeheartedly because I see it. Like there's some very guideline-based treatments that can be very harmful to patients. And I think if you understand context where that exists, and I think, can you speak to that a little bit?
Yeah, I think, so first of all, guidelines can be shaped in any way that biases the clinician to a greater or lesser degree. So if we take back pain, for example, when patients have gone through episodes of, for example, best practice care, physical therapy, multimodal kind of approaches, and they face an MDT, one of the options that's guideline based is say medial branch block injections plus or minus radiofrequency denervation, or if it's in the case of a sacroiliac joint problem in the UK, if people have failed physical therapies, they go through into an MDT situation, they've had some pain provocation tests which are positive, they have an SIJ injection which improves their symptoms for a short period of time, then they'll fuse this SIJ. There's so many reasons why I'm not sure. I'm very suspicious of that. So we know that, say, for example, the sacroiliac joint injection that can have a general steroid effect. I know that there will be some surgeons who'll push back quite strongly on this, but they'll say that, yes, well, there'll be a local anesthetic effect. We know that that's the source of the symptoms. They'll also do post hoc reasoning where they say, oh, yeah, so there is this number of patients have got better with the sacroiliac joint fusion. But, oh my gosh, how many patients have not done well with the sacroiliac joint fusion? That's following guideline care. That is following guideline care. That is just some concrete examples. If we go to, and that's fairly strong hardline orthopedic ones, which are in themselves quite controversial. There are lots of people who would say that that's not best care per se. But let's say if there are patients who we follow guideline-based care, but their social circumstances are so incompatible with what they're available to access in terms of the guideline, we can't provide care according to that guideline because their particular circumstances mean that they are unable to get access to the guideline. Hence, we need to reshape how we help that patient. And there are all, and in the paper, which is going through peer review, and we shall see where that goes, but there is a case study example of a patient who is based on a real case. where their social circumstances, without putting too much emphasis on this, is just means that they are not able to follow the guideline. Hence, we have to reshape the guideline for the patient. Now, some people will come back at me and say, of course, guidelines can be reshaped. You can choose not to follow the guideline. The pushback that we get from clinicians, insurance companies, and all sorts of other things for not following guidance is pretty strong. Even though we're following or trying to be the best evidence-based clinicians that we can be, where we're coalescing those three aspects as we talked about earlier. So yeah, that's basically where at times following a guideline may actually cause the patient harm. It's basically where what that was trying to get to.
No, I liked it because I said I've seen it, and SI joint's a great example of that. I think in the UK you are much more adherent to guideline. In the US there can be not as following of guidelines from just my talking to you and other clinicians.
Yeah, so guidelines can be seen as tramlines. That's one of the issues. I think when it comes to guidelines, if there is that recognition of a broader scope of what a guideline is, then that's okay. But unfortunately, there are times where guideline is not a guideline; it's a tramline. Mm-hmm. It's like if you step outside that, you're not practicing properly. In fact, actually, the pink finger gets pointed to you as the clinician, saying that we are practicing unethically, and it's a difficult pill to swallow for some. Where I'm trying to help the patient in the best possible way.
Another thing you said in this paper that you had kind of argued that these 4 pillars, we're going to get into value-based care. You'd mentioned, I think, Chad Cook's paper on value-based care.
Really nice paper.
Yeah. Good paper. You argue that those 4 pillars of value-based care contain some inherent frictions rather than being naturally synergistic as they're kind of portrayed in that paper. I'm wondering which of those tensions you think is the most kind of maybe underappreciated in day-to-day practice.
So in the paper, I hope it gets published because you'll be able to articulate it far better than I can from memory now because we submitted it some time ago. But there was, so basically it comes around to the idea of what value is. So this is a bit of a sideline I'm going to talk about because if we look at evidence-based practice, it's a values-based model. And then I'm going to come back to Cook's paper. So if we look at, and people are probably thinking what you're on about, evidence-based practice being a values-based model. In practice, the EBM or EBP model, best of the research, best of the clinical experience, and best of patient values are all value-laden. That is not an obvious claim, but it is a claim that I stand by. So when the therapist selects the appropriate evidence, they're making a values-based claim on what they think is legitimate evidence to apply for that patient. That's a values-based claim. Someone would come back to me and say, yeah, well, no, that's not the case. That's not the case. Because you're following guidelines, that's being predetermined, it's sitting outside of that. I'd still say that how the therapist applies their practice will come from a value on what research evidence has informed their practice, and it may have been an inherited form of practice from their supervisor or so on, but I'm still saying it's value-based. Then you've got the clinician's experience, but of course that's values-based. And then, of course, you've got the patient's values. So value is the challenging and tricky concept here, and that creates the tension. So in Chad's paper, which I think is a really nice paper, it talks about values-based care, talking about low value care, cost effectiveness. Gosh, there's 4 dimensions of it, and I can't quite remember how they coalesce now. But essentially, all of those factors does depend on the context into which the patient and the therapist encounter each other. It is not set that the value that person, the term value is going to be contested. There's going to be an inherent friction between what is best practice and what is low cost, and what is perceived by value from the patient and from the therapist and from the system. So if we see the system's value in terms of patient experience or in terms of economics, that may be very different from the patient's value from their own perspective as opposed to a self-reported measure versus the clinical guideline or the clinical research that they're coming together. I think in principle, it sounds good. It sounds like they all come together quite nicely. But as soon as we talk about the social determinants of health, as soon as we talk about the environmental contexts and the social political environments that these people come from, now we have a very different ground of contested ideas about what value is. And this is why I'm not making any negative claim against Chad Cook's paper. I think it's pretty good. I just think it requires a form of fluency of understanding of knowledge and an understanding of what value is and how you apply that knowledge in practice.
In context,
in context.
Yeah, where we don't know how those 4 factors or 4 pillars are realistic for the context that this person sits in, and the context you may sit in your situation with that patient. The other thing you spoke about in this paper that I noted is it mentions AI evolves to handle population level pattern recognition. The clinician's irreplaceable value will shift towards situational understanding, and you used the phrase, and we talked about this earlier, the contextual engineer. Do you think the profession understands what that shift actually demands of our identity? Like, it's kind of a shift a little bit, right? Of that. I'm wondering, I'd love if you can speak to that.
Okay. So I'm going to go back a step and make a suggestion about what might happen when AI really takes a grip of the healthcare context. So I think that healthcare is going to hit an irreversible change. And I'm not saying this is good, bad, or indifferent, but I think it's going to change. One of the things that I think AI is going to do extremely well is manage musculoskeletal conditions in certain ways. Not for all, but in certain ways I think it will. And in particular, how certain musculoskeletal pathways are managed in a very algorithmic way. This is going to be AI's, like a piece of cake for AI to consume, where we've reduced health care in a musculoskeletal context in such a way that it's follow step-by-step rules that AI is just that's bread and butter for AI. AI can do it way faster than us, and it can be a 24/7 therapist. I'm not saying this is bad. I'm saying it provides the physiotherapists with quite a lot of opportunity for the future, but in very different ways, not in the ways that we're currently practicing. So what does that mean if AI kind of comes in and is able to manage populations using evidence-based approaches and following, and pretty dynamically, I'd suggest, those evidence-based pathways? What place does the physiotherapist have? And I think the physiotherapist has a place as a contextual architect. Basically, it's following on from Michael Rowe's work, and he's published a book, I think, coming out soon. I haven't read it, and I don't think it's published yet, but he's written some really nice articles, and he's spoken at conferences, including IFOMT, where the physiotherapist will have a place either to interpret some of the information and knowledge that the patient has come to them that they have gleaned from AI and to situate it for them, or to be able to support the patients to use the AI in such a way that it will help them. So that's one of 2 ways. There's going to be at least 3 or 4 different ways, but essentially the idea of context being a situated form of practice that sees the patient as more than just a single entity, to see them as in a multidimensional multidimensional context, will provide physiotherapists with a way to interact with certain forms of technology in a way that will support that patient, I think, in a fit for the future, I'd say, in AI. So that's probably where I would say things are going to go. We're going to be involved in kind of contextual architecture, supporting the patient in their own individual context.
Which I love. And I hear clinicians, and not just in PT. I mean, you see this in other, especially ones that are more algorithmic, triage based. Primary care, I think, has some understandable concerns that I would have too with what we're seeing with AI. I'm a firm believer that if we leverage it the right way, it allows us to really leverage our humanity components, right? It can let us lean in and have some of these, the more humanity components of our care that, it's hard for AI to sit with a patient and just share a room with their suffering and empathize and validate and do things. Of course it can validate. And so we all know AI sometimes can be very syncopathic with its validation. And, oh, yes, Mark, that's the greatest idea ever. You should do that with everything you tell it you're going to do. But I'm wondering what your view is on that piece as far as like AI's ability to help us, maybe remove some of the administrative burden from us. Cause I'm thinking more as like a clinician aid to help us like get to the meat and potatoes of like what it is that truly separates us as a profession. That maybe it is touch, maybe it is, other things of what we do. I'm wondering where you sit with that.
Yeah, I think it's interesting we're saying things about the kind of narrative aspect of what AI can and can't do. I mean, there's research papers to show that it demonstrates empathy. AI demonstrates empathy better than doctors. I'm not sure if that's, I know we're not doctors, but I think it points to something. So I think that AI will get to the point where it will be able to take a history. It will be able to, which I think it can do already, and pretty accurately, I'd say. It can demonstrate empathy. I'm not saying it's going to be perfect. I'm not just going to say it's better than physical therapists. But I think, it will be able to do pretty much everything that a physical therapist can do, albeit currently within large language models, it won't be able to do the physical aspects, of course. And there's all sorts of talk speculatively about where this is going in terms of treatment robots and so on. Apparently in Japan, they have massage robots and so on. Anyway, that's a different conversation. So I think where we're already seeing some of the benefits in physical therapy departments is the use of, although you have to change your practice when you use it, is automating of record keeping. I think that is a game changer, particularly for burnout clinicians who just go behind for every single patient because they're putting everything into their patient and then running behind on their notes. They know they've got to get their notes done by the end of the day, and they spend like an hour or two after the clinic. Like we all know, we've all been there. So I know that I'm pretty confident ambient technology is going to be, and that's already here. And it does change the way you practice, of course, because it can only pick up on stuff that you say. So much like the work that you currently do, Mark, when you've got students in front of you and you're talking through what you're doing and what you're thinking with the student, you'll have to adopt that with the patient. Of course, you'll have to have their consent, and they'll have to know that all of that. Have you used ambient technology for record keeping?
We've experimented with it a little bit, and just like recording a transcript, and then we don't have it like live with it, but it basically it recorded the entire thing, and I just shoved it in, and it spit out a
pretty good. So there are ambient technologies out there which does it real time. Like there's no kind of recording stop, that kind of, and it will put that all of the context and the content. The difficulty is it's audible content. So there's all sorts. You remember I was talking about the different forms of knowledge, testimony, technique, phronesis. It won't pick up the implicit forms of knowledge, the stuff that you see implicitly, unless you make it explicit. And that can be challenging because there are going to be times where you've seen something, you've understood something, but you've not said it. And that's the phronesis. There are times where it's just not the right time to say something. So there are going to be things but anyway, my point is we've got ambient technology, AI, and that is now, that's going to be taking away some of that administrative burden. I think triage, referrals coming in. I think that, gosh, how much time do we take doing triage? Doing it fairly manually. There will be places who have already got that automated pretty well. But for a lot of us, it's a long, drawn-out process. There will be some safeguarding challenges that we all need to overcome, but I don't think it's going to be too long before all of the triaging process goes in. I think that there will be stratification of care where, say, for example, on a start back measure, which is being taken up in different parts of the world to various degrees, or use of Arebro measuring tools and stuff like that. If we stratify patients, the lower risk patients can be managed with AI, and then if they get into trouble, they can then come in to see a physical therapist, and so on and so forth. So there are different ways in which we could stratify care. So I do think that is going to take away, full positive or negative, it's going to change the way we practice. And that, I'm not talking too far in the distant future. This is now. This is already happening.
Everything I hear you say is something that is the capability is there at the moment. So it should have us take pause of like, we need to be having some serious considerations of this. We spoke about this, but I want to bring it into obviously our listeners. Do you feel like there's any movement? Because, you know, we've had this neoliberal self-empowerment, creating autonomous patients that can self-manage. That seems like AI would be really good to help that happen. So do you feel like you might see a retreat of clinicians back into more hands-on, touch-based care? And
I think there will be some clinicians who will double down and they will go, I'm digging in, I'm a hands-on physical therapist. We're going to be going back to old traditional values, and we're going to, you know, this is very, very similar. If you look at a paper that Dave Nichols and his colleague wrote, I've forgotten his colleague's name, wrote back in 2006, right, about the future of physiotherapy. And he divided it into 4 different characteristics. The kind of, and I'm going to use the wrong terminology, but essentially they are the holists, the ones that try to take on everything, but then ultimately it's very difficult to teach in a curriculum. You've got those who are going to be back to the body as machine and double down on that. You've got the people who are going to go, you know, these are the 4 directions. If you were to go down in one direction, that would be doubling down as the body and machine. Go in another direction, you could go holist, and then you lose your identity. Go into another direction, and you could basically become kind of a radicalist in a sense, where you practice in a way that's almost unrecognizable from a physical therapist perspective. And then there's the other one, which is, I think it's kind of like you're going to add so much to the curriculum that it's going to be impossible to teach. I think there's going to be an element of where I think a lot of physical therapy practice is going to be relatively the same, but for not that long, maybe 1 or 2 years. After that, you're going to have various forms of practice which you're going to double down. It's going to double down as the body as machine. But I think that there will also be the opportunity for physical therapists to practice physical therapy in a broader way. There's an opportunity. And that might mean that we practice in a much more social context. Or it might be that we think social ecologically. We might be looking at our own environments, become part of neighborhood therapy teams, be able to look at communities of practice or communities where we work with third sector parties and work much more closely with vulnerable parties, for vulnerable people. And I think that'll be a good thing. Whether or not it will be funded, that's a different question. But does it open up the possibility for that far more legitimately? Yes. I think as well, AI, because of the way that it's going to be practiced, there will be those that can afford therapy, and there's more of a possibility that therapy becomes a commodity. So there is the possibility that only the rich will be able to afford physical therapy. That's another way that this could go. So AI will take on the majority, and if you want to have physical therapy with a human, you're going to have to pay for it. So I'm not saying that's a good thing. I think that's a possible direction that things could go.
Yeah, and that kind of goes with my next question I was going to ask you. I mean, that's obviously one of them would be like we all of a sudden lose access for, you know, and it becomes something the wealthy only have access to. Any other concerns you see out there, or any other like kind of things you would be concerned about, you know, AI not helping or moving us in a positive direction, or maybe being used in a way that is not maybe what you would consider ideal? Like, what are the, like, maybe, I guess, worst case scenarios you would see? I mean, we don't have to go doomsday here or anything like that. Like, you know, the world will continue. Hope, you know, obviously maybe we just want to stay blissfully aware of like some of the risks that are out there. I'm hearing things about Mythos, Anthropic's new model. They won't even release it to the public because they're worried it's too good. It's hacking everything. They're bringing a consortium of all these big companies to say you need to figure out how not to let this, how to protect your software against this. So there is some understandable concern out there with AI, and that, I mean, maybe that goes beyond this discussion. But I'm wondering any concerns you have of maybe the misuse. Again, you just brought up a huge one with maybe it's AI for the masses and true human centered, one-on-one human care for those who can afford it. Anything else that you see that might be a concern as AI is adopted?
I mean, that's already built in some AI models, and the way that it comes out is its inherent bias. So it's being, so it's whatever data is fed into the system becomes amplified potentially. So the way that it treats certain populations may have that inherent bias baked in. Okay, so that's one of the risks and challenges. I guess the other is kind of safety features and red flag in safety rails with how that all who takes ownership, who takes responsibility for that. Is it at the moment, if we deploy AI, be that ambient technology or otherwise, the clinician holds the can for that. The clinician takes responsibility. In Cambridge, in the UK, there is a procurement that's probably coming to a close, or if not finalised, for musculoskeletal services that are going to be taken over by AI. Or AI is going to be running some, not all, but some of its musculoskeletal services. So this is already happening. And I guess I think the pilots of that have shown pretty good. We can put a link in the show notes for that.
Yeah. And
I think some of the pilot studies have shown fairly good management of red flags and management of safety. But I think, again, I don't know how sensitive that is, and if it's oversensitive, what clinician burden that has. If it's not sensitive enough, what then goes on after the fact, and then the legal ramifications. Who takes responsibility for not just the deployment, but the ownership and the responsibility of that patient care? Now, within the UK, my assumption is that as soon as your service accepts responsibility, accepts the referral, you accept duty of care for that patient. So therefore, it would reside on the part of the service and not the AI company that's created it. So there's plenty of things to think about in that kind of very proximal aspect of AI, not even just the kind of more speculative aspects.
Anything that's got you excited about AI? I mean, we've talked, but what's got you like genuinely excited of like possibilities with it? Because I think we all to me, I get nerdy with the coding and the tech and our ability to bring clinicians having no need to hire a software developer, or at least, they can code a lot and do this with some basic software development, and then obviously maybe consult and make sure we're doing it all by the book. But anything that's got you genuinely excited about?
I think the way that it can bring together different forms. Now, I'm not quite sure how it does the analysis of this, but how it can bring different forms of data might be quite empowering. So the example that I gave in regards to how it handles heart rate variability, heart rate, resting heart rate, blood pressure, biometrics, how you can program in or at least be able to work with the architecture of AI to be able to support recovery programs so that the AI could become a physiotherapy assistant who works independently with that AI. The patient works with the AI like a physical therapy assistant who provides supportive advice. Enter into enter in like a genuinely collaborative form of care for the patient using AI that can guide by the side and work with the patient over weeks and alert the patient if they need to contact us for some updates, maybe for an update physical examination assessment or reorientation of the AI with support. So there would be 3 people involved in that care. 3 entities involved in that patient's care: the patient, therapist, and AI, and all of them working, together. I think that's a really exciting possibility. Again, how we shape the context is going to be of utmost importance. Hence, I return back to this idea of epistemic fluency, the different forms of knowledge that we're trying to work here. What are we trying to orientate this toward? What's our direction?
Totally agree. I think there's some exciting times ahead, but using due diligence and really having these considerations in mind when we're deciding how we're going to apply it. Because I'm sure there will be those that rush to market, and that's what we see with AI development. It's generally everybody wants to get their model front and center and win the race, and safety rails be damned at the moment. So hopefully that doesn't cause any issues. But I feel
that is the issue right now.
Yeah,
safety.
and I just feel the same with our adoption of it too. I think we just need to be careful and make sure there is no harm being done, and really spot checking. You hear, I just watched an episode of The Pit not too long ago. It's the great show. It's kind of like the modern day ER, but it had an AI scribe that kind of had an error in it, and it ended up having some interdisciplinary miscommunication, and some older clinician came in storming, "You see this AI?" And so, I mean, I think there's definitely issues we need to be aware of, but I think some, again, exciting times ahead is and making sure we, again, don't let it lose sight. To me, I think it's exciting opportunities to maybe provide some coherence with that knowledge, and maybe, debias some of our things, because I think we can debias things with AI. What are your thoughts on that? Do you think it can help us maybe limit our human nature of bias? And you mentioned some good points, though, because I spoke about this before in a talk I just did recently, about how a lot of the data that forms and trains this is biased data. It represents a predominantly Western, Caucasian, population. There's women are often underrepresented. There's a lot of issues with that data that may make it challenging. I'm wondering what you think.
I absolutely agree. I think when it comes down to the opportunities for AI, that ability, there is so much potential, but it really does come down to how the AI is trained. That's going to be critical, because you would want the AI to push back on you as a clinician and say, "Are you sure this is the right direction?" Or maybe with the patient, not to be too sycophantic. "You're doing a great job. You're doing da 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 da." That's fine if it's encouraging and it's situated in the right time in the right place. There's times where that's not the right thing to say, and it's not the right thing to do. So it's trying to get that, again, comes back to my point around epistemic fluency, the timing, the phronesis. When you deploy knowledge, when you deploy information, when is the right time, and how do you do it? But I think it's got the possibility for us as a clinician, for example, to push back at us and ask us serious questions. I mean, this should happen in peer review practice anyway, but we know how challenging practice can be and how peer review sometimes doesn't happen as much as we'd like, where people should be observing us and giving us some critical feedback. But let's imagine that you're using AI as a third entity between the kind of partnership. And then you ask the AI, "Do you think this is the right direction? Am I missing anything? Tell me why this isn't the right thing to do." That's quite an interesting thing to do with AI models, because they come up sometimes with some very insightful things. When you ask it to tell you why why isn't this the right thing to do? And you're like, "Oh God, I would never have thought of that." So that is something that I think AI can sometimes just poke us in the side and say, "Hold on a second, there is something else that you probably need to consider here." And a blind spot that we would never have necessarily explored becomes available.
Yeah, I could see that being like just a great clinical companion, right? And not just a yes man syncopathic voice that's just reaffirming all your decisions. One that just pushes back, like you said, and rightfully so. And then, I mean, because I've even had it with students, like, I didn't even think about that, like, or just I overlooked some things that they rightfully brought up, and had me, change course and things. So I think having that ability, and kind of jealous, like if that's what's happening for a younger clinician, I would have loved to have that voice, of like reason and, whoa, are you thinking of everything? I could see how this, being trained as almost, I don't want to say a mentor, like an AI, I guess maybe, with like, but that becomes a slippery slope, of course.
It does. That's a really interesting idea, isn't it? Because first of all, we've bestowed rationality upon the AI there, which is an interesting idea. But essentially it's predictive, and it's trained on, it's trained on repeated forms of knowledge. Like it's, gosh, I'm forgetting what the word is. Oh, it's been trained on volumes of repeated data. It's very good at
Like pattern recognition.
Pattern recognition.
Yeah.
Yeah. So it's going to be picking up on the things that you haven't seen based on pattern recognition and forms of prediction.
Which is
Is
kind
that
of what
rational?
we talk about in clinical reasoning, right?
Is
a lot
that
of
rational?
pattern recognition.
It's a part of it.
Yeah.
And here's the other thing, so you've got gut feeling, haven't you? The embodied tacit forms of knowledge that makes you think, actually, look, I know this patient says they haven't lost weight. I know that they've told me that, they don't have these red flags, but there's something not right.
Yeah.
And you pick that up, ask for further investigations, and something serious has been picked up. Right.
Yeah.
And, it not quite yet. I'm not saying it will never happen, but at the moment that kind of tacit form of knowledge, it's nowhere near.
Yeah. And it just seems like there needs to be so much context that you as a clinician use to form that gut feeling, right? That, even with that pattern recognition and training of all this data, I just don't know.
Well, at that time, we might find that we can provide biometric kind of scans, biometric data, so that all of those things, the iterative stuff that we would have otherwise seen clinically, the AI may have picked up instrumentally. I guess that's what some of the transhumanists would say. The transhumanists are the people who basically think that technology is going to save us, they're going to improve our longevity, their lifespan, and so on. They would say, actually, AI is going to get to a time where we just basically augment the human with various biometric scanning forms of information and data, such that you don't need that tacit form of knowledge anymore. The data will tell us. We'll have an ECG all squared up. We'll have EEG. It's not a problem. Well, we've already got their pulse, heart rate. We've got all their bloods. No problems.
Yeah, I mean, this just it bends my brain a bit, because it's almost that like hyper determinist way of looking at like the way things work in the world, and I just and again, maybe I'm just the determinist volley going on myself, where I just don't know how and it goes into a lot of questions philosophically, I know, but how an AI can just see how these ping pong balls are all bouncing off each other and predict perfectly. I just think and again, it's my philosophical position, that there are just things that are not the black box up here, consciousness, right? It just doesn't seem to me that is something that is, and again, maybe I'll be proven wrong, and it's happened many times before, and it'll happen again, but it just does not it just bends my brain to think that AI is going to be able to step into that, and it's all just the data, right? We're all data points, and this is this hyper determinist world. Sapolsky's book was another one that was a real, Determined, I think.
Determined.
It's a great book, and I'd highly recommend it. It definitely had me thinking, which is a good sign of a great book. What do you think? Like, because in a determinist world, the AI just
could do it.
Could do it.
Yeah.
Like, they just need to know all the variables at play, and AI has a massive capacity to understand an immense amount of variables, more than we can hold in our brains, and even when we can hold in some of our research models that we're using.
Yeah, 100%. But I don't hold that philosophical view. I think if we look into physics and we look at quantum mechanics and we look at quantum fields and fluctuations, it's indeterminate. So even at the base levels of what we believe is reality, it's indeterminate. We cannot predict. We can predict with a greater or lesser degree of we can predict to a greater or lesser degree of determinacy, but it's not determinate. It is indeterminate. So as soon as, for example, an observer comes into that situation, it changes the game. And there are effects. The whole idea of cause and effect becomes completely up the wahoo as well when we go into the kind of basic levels of reality. So do I think that the world is determinate? No. Do I think that reality is processual? I think it is. It's not the start point and end point, and it's a line between the two. I think I think reality changes and evolves, right? So even as we sit listening to this conversation, everything's in motion. your bone turnover is happening. You'll be shedding skin. What part of Mark is Mark yesterday as is Mark today? You're going to be physically different, and it will have a tendency toward Mark, but it won't be the same Mark. You'll as time goes on, you're not going to stay the same. Nothing stays the same, and everything moves, and it is indeterminate.
Yeah, and that gets into what we spoke about earlier when we weren't on camera, but is this whole thought of stasis, right? This thought of like this belief that we hit, and that's always been my contention with like this like precision biologics is another one that I'm like, that you're aiming at a moving target. Like the biology is ever changing, like at every moment. It's like you said, bone turning over, electrochemically, who knows how much complex stuff's going on in immune and different things are shifting. You offend me, I get all sorts of chemicals going on in my system. You make me happy. I just, this belief that there's some just like, we're going to, the physicalist, and that was where it's off. I think it feels like we're going, like we're just going to need, is once we get the data and we can just precisely target it. But that's making some assumptions in my book that we can have a static human that is going to respond to a treatment consistently, and that's where I just don't see it. Where are you?
Yeah. I think Asaf maybe, in his defense, might be saying, look, okay, even if you were to say that everything's processual, everything moves, there is so much familiar repeated patterns in the nociceptive apparatus that we'd still be able to target it, even though it's not the same. This familiarity of iteration, which keeps happening from a kind of nociceptive apparatus, would be so similar, even at an individual level, if not a population level, that we'd still be able to target biochemically what is driving a patient's pain, and therefore be able to augment it, change it, dissipate it, whatever word you want to use to be able to interact with it. And I think, again, that's fine, but it's not my view. I would say I'm quite happy to, but I'm quite happy to have my mind changed. So yeah, I think that I agree with you. If we look at biology, even biology, but I'd say this is true of any whichever system or sphere that we look at. It's process orientated, it's relational, it's historical, so epigenetics gets involved in this. It's process-based, relational, and it's indeterminate. Those are the key kind of key concepts I think that we've got to take forwards. That doesn't mean that data isn't helpful. We've got to recognize that these data points just don't tell us an absolute answer for everything for all time. I think we'll be able to collect information, but even how we interpret that information is going to be somewhat limited. It's not going to predict everything. It won't.
Yeah.
Might tell us a tendency, but that's as far as it can go, I think.
And to me, that just becomes like there comes a point where, all the data in the world can inform, but in the end, you have to have, something to a human to try to help move somebody in a direction with, and maybe hopefully be informed by as much of the data as possible. But to me, there needs to be a human in the loop.
I think at the moment, for sure, it seems that, when it comes, and I see this as an opportunity, that if we conceptualize, I agree. I think we will, certainly for the foreseeable, there will always need to have degrees of human interaction. But what I hope this offers us is to look at health in a radically different way, such that involves understanding health not residing just as humans, but in terms of ecosystems, thinking ecologically, thinking about climate crisis, the planet, planetary health. Because at the end of the day, all living life goes through a cycle. We born, we grow, we die, we return to the earth, and we give our energy and life sources to other non-human entities, and we consume non-human things for our own life, gut microbiome, oxygen, and so on and so forth. So I would be really interested in how physical therapy could really be a much more ecosystem-driven profession.
That brings me to some discussions on your physioethology paper. This will be broken up into some episodes because we're going deep.
Yeah.
You had proposed in there in your physioethology paper that a pedagogy that orients a student towards ecological composition and experimentation rather than diagnostic protocol. I'm wondering, what would that curriculum look like for a physio student to maybe orient them that way? Because that's a tough. We're so ingrained in the way we train. I love the thought, and I agree with you. We need to look beyond the clinic walls to understand, to really get a good context of a human we're serving, and it could look, social determined, ecologically, environmentally, planetarily, like you said. What do you think that kind of would look like for educational experience for
curricula? Yeah, it's gonna look very different. You wouldn't look at human-centered importance. So you wouldn't, for example, focus on the anatomy and physiology of a human. That's not to suggest that anatomy and physiology isn't important, but it's to suggest that in the context of life and death, let's call it life cycles. Life cycles require a ecosystem perspective, and that basically what I suggest in the paper is that we have to. Oh, sorry, have to is too strong. It is in order to orientate us that way. I think we probably need to decenter the human in that system. So by focusing a lot of models, even when we think of ecological care or ecosystem-based care, you still have the human at the center. So you have the human at the center, the communities, the environment sits outside that, and the ecosystem and so on, planet and so on. But the human's still in the center. Well, what that does is that still means that any kind of curricula needs to focus back onto the human. And so rather than focusing on human-centered health, we think of health, what consists of health, what provides life, and what diminishes life, and how do those systems interact. And what we're going to be looking at is a theoretical system that's far more relational. In other words, thinking of the connections between entities. We're going to be thinking about the interactions between those entities. You're going to be thinking about life cycles. You're going to be thinking about all of the porous barriers that interface between them. You're going to be thinking about the interaction between human and non-human entities. You're going to be thinking about oxygen, carbon dioxide entering gaseous exchange in lungs, which we accept, but when does the human begin and where does the human end? Gut microbiomes, for example, we know that has an effect on, or we believe that has an effect on immune systems, and also perhaps with the has engagements and relationships with persistent pain, for example, but that's a non-human entity. So in what ways do these human and non-human elements interact? And so I think that that's where the curriculum starts. It looks at life cycles. It looks at interactions. It looks at the broader kind of relationship between biology, physics, chemistry, in a far more broader sense. And then it can focus on the physical, whatever we would like to kind of, if we need to narrow it down, then we can, of course, narrow it down to aspects of physical therapy. And then we start thinking about, what does therapy mean? That opens up another conversation. What is therapy?
That is, and we'll have to touch upon that, because we're getting into some deep philosophical things. And I mean, this is why I like these discussions. In that paper, you kind of talked about how our boundaries need to be more amoeboid than fortified, right? Where we may need to be able to move our boundaries. Like, how do you see that? Is that something you think that's happening kind of right now, or is that something more aspirational in your view? Or how do you, where are you actually seeing those boundaries maybe dissolve in productive ways?
Yeah, it's really good. It's a good question again. I think it's got to start from a position that kind of extricates ourselves from our current institutional barriers. I want us to, we may have to speculate to start with, to imagine what might be possible before it becomes actualized. And so one could quite imagine how a physical therapy, as I use an example in the paper, recognizes a health-related impact that really impacts their community and their society of where they're situated. I use the example of homeless people near in a seaside area. I live near the seaside. there are lots of homeless people in around that area, and they seek shelter underneath the local pier. So there is something around how physical therapy. What is therapy? Therapy. I draw from Greek, so I'm going to come back to this. So, what does physiotherapy mean? Physiotherapy comes from the Greek root words of nature and therapy. And so it's not something that's specific to a human. And we can go back to that. It's been an institutionalized name, and there's lots of good reasons from that. And as I mentioned before, we bear the privilege of that, but it also limits us. And I think if we were to imagine, if that was a real problem in our environment, in our community, in what ways could we help those vulnerable people? So, for example, if you were residing in a town with a high level of veterans, we use this as an example in some of our conversations, where veterans were having a rough deal on how their health outcomes. They have poorer engagement and access with healthcare. They may have poor outcomes with their interactions with healthcare systems. How can we go out to them and serve them in the way that makes sense to them? And we don't have to, and that's a human-based example. But you could use that in environments that give them calm, give them solace. You can go out to nature, for example. So that is a form of physical therapy, to be able to build relations with people and their interactions with their environment and all of the various things that enhance their life cycle in multiplicity of ways. And in the paper, I try to talk about how we analyze these aspects of what gives life and what doesn't, through longitude and latitude. And so I use philosophy from Gilles Deleuze and Félix Guattari, who are French philosophers, to build up this kind of map. How can we become, for want of a better description, cartographers of care? How can we map out the possibilities in using physical therapy to support not just humans, but our co-constructed, cohabitating entities that provide support for health in a much more broader scale? And that would also help support our environments, which may also support things like planetary health, because we depend on the planet for our health.
Yeah, no, I like that line of thinking as far as, looking health beyond just our human-centered way of looking at health. What is health? And looking at a big picture, maybe that also equals planetary health and a lot of the things, especially when we talk climate change and different topics. I'm going to leave it. I want to kind of maybe land the plane with the last question for you, because we could probably talk for another few hours, and we're already at multiple episodes at this point. You close with Deleuze's line, "An animal, a thing, is never separable from its relations with the world." If you had to maybe translate that into a single clinical principle a physiotherapist could carry into their next encounter.
Yeah, I mean, I think Deleuze is already describing something that is an organism, which is never separable from the world. Any entity is not separable from is inseparable from the world. But let's use the human animal as an example. Is that the ways in which we interact with everything? It is not just based on if we look at the biopsychosocial model, that's a very anthropocentric model. It focuses on human biology, it focuses on human psychology, and it relates to human sociology. But it's common sense for us to go, actually, we are inseparable from the sitting here with the electricity that's going through this house that's powering everything. We are connected to the wind circulation that comes from the fan, from the air conditioning that's drying out our pores as we speak, and from the energy resources that is going around us, from the distributions of water that come through and out of through the house. All of those elements, just talking about a human environment, is inseparable from the world. So the oxygen, the carbon dioxide, the inhabitants, the non-human inhabitants of my own body inside of me, and externally. So all of those things are in relation to me. They're not human, they're non-human. And if we think of health and life cycles as being inextricably linked to all of those things, then it radically makes opportunities available for us to rethink the physical therapies in ways that can provide therapy outside of our musculoskeletal physiotherapy ways of practice.
Yeah. Outside those four walls you described, or the sterile non-paintings, little plinth sticking out there. It's just kind of that view we all tend to have of a physical therapy clinic. Well, Matt, I just want to thank you, one, for blessing the studio for the first annual in-person recording. Hopefully we have more of these. We're going to hopefully get some guests that will come into the studio. Hopefully we'll deliver some courses here, both virtually and then in some space here in Arizona. But thanks for joining us for the first go-round.